When you're designing a treatment regimen, you really want to design something that most closely mimics your normal patterns of insulin secretion. So the reason that I'm bringing this back is to just kind of give you a framework as to why we provide exogenous and supplemental insulin regimens in the way that we do. So remember that 50% of your insulin secretion is going to be secreted as your basal insulin, and then your insulin bolus is going to occur in the first 10 minutes after eating, and that's going to be typically done 3 times a day. So it's really important to kind of remember that when we talk about the methods in which we provide insulin supplementation. In patients with type 1 diabetes, your average daily requirement for insulin is going to be about 0.5 to 0.6 units per kilogram, and you're going to deliver 50% of that as basal insulin and the remaining 50% that's dedicated to meal coverage. Immediately following diagnosis, most patients with type 1 diabetes will actually fall into a honeymoon phase where they'll actually have a little bit of residual insulin secretion remaining. So then those needs may fall, but then over time you can estimate that most patients will need about 0.5 to 0.6 units per kilogram to meet their glucose goals. And when compared to type 2 diabetes, keep in mind that overall type 1 patients will have a lower overall insulin need because there's no insulin resistance on board. So the best way to deliver an insulin regimen for a patient with type 1 diabetes is going to be using a true basal bolus regimen where you're going to give that long-acting in the formulation of glargine or detamere once or twice daily if you're using low doses of detamere, with a rapid-acting or short-acting insulin with each meal. However, the limitations with this, although it more closely mimics physiological secretion, is that it is very expensive. In addition, it requires multi-doses of injections a day because Lantus or detamere cannot be mixed in the same syringe as your rapid-acting insulin. So patients are going to be required to take their basal insulin, often given as a dose at nighttime, and then 3 mealtime insulins throughout the day. In contrast, there is combinations that are out there that will provide patients NPH and bolus insulins in the same syringe. So combinations such as 50-50 NPH and regular are made up of 50% NPH and 50% irregular, or 70-30 is made up of 70% of NPH and 30% of regular insulin. And for those patients, they really take that injection prior to breakfast and then prior to dinner time. And then that NPH is going to give them that 12-hour extended basal coverage where that meal time in that injection is going to cover that meal that they're eating. Now the benefit of this is it reduces your injections to 2 times a day. However, there has been an increased risk of hypoglycemia with these formulations, in addition to the fact that it doesn't as closely mimic your normal physiological processes. So here you have your pre-mixed products such as Humulog Mix 75-25 and Humulog Mix 50-50, Novolog 70-30, Novolin 70-30. So you could see that that first number represents the percentage of NPH, whereas that second number represents the percentage of your mealtime insulin. Another problem with this type of insulin is that it is very dose limiting, in the case that if you give 10 units of insulin twice a day of a mix of 75-25, 75% of that 10 units is NPH and 25% is your rapid acting. So it limits the flexibility that patients are offered in terms of if they have different meal times or if they're experiencing hypoglycemia, you're really limiting as to what you can do with that patient's individual insulin dose. So the most common adverse effects reported with insulin therapy are going to be hypoglycemia and weight gain. And hypoglycemia is going to be more common in patients who are on intensive insulin therapy regimens versus if you have a patient with type 2 diabetes who's just on a basal insulin that provides their coverage. And hypoglycemia also occurs to a higher degree in patients with type 1 diabetes. And the estimation is that in 10 years, most patients on an intensive insulin therapy regimen will require some type of support for a severe hypoglycemic reaction. So minimizing the risk of hypoglycemia for patients using insulin should include education about the signs and symptoms of hypoglycemia, how to properly treat it with a fast-acting glucose formulation that does not have fat or protein in it that then delays the absorption of glucose, and then blood glucose monitoring. And then treatment of hypoglycemia is going to require the indigestion of carbohydrates, with glucose being the preferred regimen. And then just make sure that you're also counseling your patients on treatment, but even more importantly, the prevention of hypoglycemia. So make sure that they're on the appropriate insulin doses, that they know how to appropriately inject, and that they know how to titrate their insulin up or down based on meal times and exercise patterns. So weight gain predominantly occurs in the truncal fat area, and it is dose dependent, and weight gain really corresponds with actually improved glucose control. So for most patients, the weight gain that's going to occur with insulin is usually going to be associated with a reduction in A1C. So while it's undesirable in most type 2 patients, it can be beneficial in underweight patients with type 1. Weight gain can really be minimized using physiological insulin replacement strategies or combining that insulin therapy with other medications that may mitigate weight gain or promote weight loss, which have less data in type 1, but there is emerging data about the use of GLP-1 agonists in patients with type 1 diabetes and metformin in type 1 diabetes, which may have a role in the future. While much less common today, lipodystrophy at the injection site can still occur. Lipohypertrophy is really caused by having patients inject into that same injection site, and basically fat accumulates at that injection site and absorbs at the site, being very variable. So telling patients to minimize this by rotating injection sites really prevents these problems from developing. And then if lipodystrophy is confirmed and detected, that injection area should be avoided. And then finally, there is some emerging data about a potential risk of glargine and cancer. Several large studies have found a potential association, but other large studies and meta-analyses have not found that association. So conflicting results are likely due to that patient selection. So the most recent prospective trial did really not show any difference in the risk of cancer in patients with glargine. So your advantages of insulin are going to be that there's no maximum dose. It can be titrated up as high as it needs to go, and it's really going to be limited by the incidence of hypoglycemia. It's going to be universally effective, although different patients are going to require different daily doses. So there is a lot of inter-patient and intra-patient variability when it comes to insulin, and there's extensive experience with it. Your disadvantages are going to be hypoglycemia, so treatment and more importantly even prevention are going to be key education components. The weight gain, which isn't as problematic in a patient with type 2 in a patient with type 1 versus type 2. It does require injection, and in patients with type 1 diabetes, it's going to require a high injection burden because they have to take both those basal and bolus components. There's oftentimes a stigma for patients, and there's some resistance to starting, and then there's significant training required to make sure that patients are injecting appropriately and minimizing the risk of hypoglycemia.